I think to teach everything, I would need an 8-hour lecture, so we'll see what I can accomplish in one. But I warn you, if you, and you're all in the nutritional field, I think to teach everything, I would need an 8-hour lecture. I think to teach everything, I would need an 8-hour lecture, so we'll see what I can accomplish in one. But I warn you, if you, and you're all in the nutritional field, I believe, so you have enough to learn and keep learning in your specialty. But if you have not had your head in the lipid textbooks, the lipid literature for the last 10 years, I'm going to rattle your bones today. Virtually everything that you were ever taught about lipids is wrong. So I'm going to try and reteach you in 1 hour. Now, my talk solely is involving understanding lipids, and especially as they relate to atherosclerotic risk. I will not be talking anything about therapy. So let's begin. I am an internist who grew up in the dark ages. I graduated med school in 1972 when I don't think we even knew how to spell lipids or what the term lipids meant. The only thing being measured then was total cholesterol, and we were told if it's above 300, you're in trouble, but if it's under 300, you're fine. We don't believe that anymore. So I've been lucky, though. In my 52 years in medicine, I've lived through every single new piece of lipid knowledge that has ever evolved. I've had the privilege of doing 4,000 lectures in all 50 states and several countries. So I was learning all these things as they've gotten, so much has gone down. So I'm sort of like, I was around when the Wright brothers invented the first plane, but now we're watching rocket ships going. So I've lived through it all. So I hope I can bring you some of the insight there. Thank you. And my last bragging point, I know you can't tell by looking at me, but I'm 78 years old. So I am a dinosaur, to be sure. But how about this? Last year, the National Lipid Association Foundation awarded me with their Clinician Educator of the Year award. Out of the thousands of lipidologists, they picked this old goat here, and so pretty amazing. All right, so let's get rolling here. My objectives are to teach you a lot about lipids, and especially most of you are probably getting lipid panels. You really have to stop looking at lipid panels, and you have to move on to the more modern blood tests that will really take you into the most accurate way to do cardiovascular risk assessment, and we'll certainly show that. Now, before I get into the meat of the matter, I want to just take you through the 280 years that we've been chasing the cholesterol molecule, and so many giants have gone before us in a stepwise fashion from whom we learn. I wish I could spend time on each and every one of these. I can't. I believe you have a copy of the slides. You can review these at your own convenience, and you can see a lot of important people discovered a lot of things. But I'd like to point out that Michel Chevreul, a French biochemist, was the first to actually name the cholesterol molecule, although it was discovered 20 years earlier. You probably know cholesterol is toxic above certain concentrations because it can crystallize and it'll kill any cell that it's in. Fortunately, most cells never achieve that high degree of cholesterol, but they can. So the first place they discovered cholesterol was as a crystal in gallstones, and you all know cholesterol gallstones exist. So that's where they found it. Over time, everybody knows the name Virchow, one of the all-time great scientists ever, and he was the first one who described atherosclerotic plaque, 1860. And then this great Russian military man, a medical student at the time, decided to feed rabbits a lot of cholesterol. Rabbits are an unusual animal. They seriously overabsorb cholesterol. Humans don't, but rabbits do. And of course, he demonstrated, boy, if rabbits eat cholesterol, they're going to get atherosclerotic plaque. And he actually demonstrated foam cells in the aorta and arteries of the rabbits. So this is where the cholesterol hypothesis evolved, that, hey, cholesterol causes atherosclerotic heart disease. Where would we be without Theodore Svedberg inventing the ultracentrifuge? We would know nothing about lipoproteins had he not done that. And actually, the first Nobel Prizes for cholesterol discovery were Whelan and Windaus, who had been studying sterols and bile acids for decades, and they were finally awarded. Michael Macbouf is another French biochemist who sort of was the first to suggest, in the blood, cholesterol seems to be hanging around with some proteins. Before that, everybody thought cholesterol was like potassium. It just floats freely in the bloodstream. Obviously, that is not the case. So he is now called the father of lipoproteins. And actually what he discovered, he didn't know it at the time, was a high-density lipoprotein. All right, well, we have to work some women into this talk finally. And Dorothy Crawford Hodgkin, a Brit, actually won the Nobel Prize. She was very big into studying crystals, and she was the first person who actually gave us the first cholesterol-accurate structural molecule. And where would we be without Tom Dauber and Bill Canal, who organized the Framingham Heart Study, enrolled first patient in 1948. Over 2,000 papers have come out of that study since then, and we're now actually studying the grandkids of the original people. John Goffman, a lot more on him later. He was the first one who put serum in a centrifuge, and we got the names very low density, and high density lipoproteins. And Lenin and Conrad Bloch really developed the details of the 35-step cholesterol synthesis pathway, and they discovered an enzyme you may have heard of, HMG-CoA reductase, the inhibition of which has probably saved more lives than vaccines. Now, back to women. And in 1959, two Yale physicians, Margaret was a physician, Albrandt was a PhD biochemistry researcher, they reviewed all the heart attacks that occurred in the Yale University hospitals up there in New Haven. And they found in men, when you were looking at lipid profiles, it was not cholesterol metrics that were telling you who was going down. It was elevations of triglycerides. So she'd be actually, I shouldn't call it a father, do you call it a mother of triglycerides? And much of what we know on triglycerides all started with her research. Sadly, because she was a woman, she had a hard time getting that data published, and the American Heart Association wouldn't even let her speak and present her data, and that's where women were back in the 1950s. I don't know if this is the biggest discovery of all time, but Goldstein and Brown down there in Texas discovered the LDL receptor. And every single drug that we are now using that reduces heart attacks works through the LDL receptor. So if we didn't know what an LDL receptor was, we'd have no drugs to combat heart disease. Russ Warnick, I have to mention, he's one of my all-time great mentors. He's a clinical chemist, a laboratorian. The first clinical chemist that was asked to sit on the National Cholesterol Education Program, they were all lipidologists and cardiologists, and they brought in a lab guy, and it was Russ Warnick. And I actually had the privilege of working with him for over a decade in Richmond. And he joined Jean Quantin, who's probably been recognized as the top ApoB chemist in America. And they put out a guideline in 2009 to ask you as a clinician, if you're not measuring apolipoprotein B in your patients, why not? And we'll certainly teach you why you should be. So let's get into the meat of the matter here. And it's lipids. Now, again, if I had the 8 hours, we could go through each of those lipid categories or so. But we're looking at atherosclerotic heart disease today. So we're going to concentrate on fatty acids. Fatty acids, if they bind to glycerol, you have glycerolipids. You know them as your triglycerides and your phospholipids. But really, the root of all evil are a huge category of lipid molecules called sterols. And public enemy number one, there it is, free cholesterol. Well, I shouldn't say public enemy number one. There'd be no human life or animal life on the planet without cholesterol. It's in every cell membrane of your body, and it's what provides integrity and functionality to your cell membranes. So you certainly need an eensy-weensy amount of cholesterol in your system. But any overload of cholesterol, I already hinted to, it will crystallize and kill any cell in your body. And this is why cells, although every cell in your body was granted by evolution the power to de novo synthesize cholesterol, because a cell needs cholesterol. If that cell, for whatever reason, synthesized too much cholesterol, if the cell didn't want to die, it has to pump cholesterol out of the cell into plasma to a cholesterol acceptor protein, which will take it elsewhere. And evolution gave every cell in your body that cholesterol efflux protein too. Now, that's free cholesterol. That's the cholesterol that can be changed into bile salts, steroidogenic hormones, vitamin D. That's free cholesterol. The overwhelming majority of cholesterol that's in your bloodstream floating around inside of lipoproteins or stored in your cell is an esterified form of cholesterol where a fatty acid is attached to it. The molecule on top is what we call amphipathic. You can see polar, water-soluble, and non-polar, not water-soluble. That's so it can interact with plasma. The bottom one is so hydrophobic it can't go anywhere near water in your plasma. So it's the storage form. Look at the molecular weights of the two molecules. One is a gigantic molecule and the other one is less. All right. So until 1940, I hinted to you that they thought, hey, cholesterol's a solid floating around your blood. And we started to realize, nope. And Arne Cilius invented this monstrous contraption, and it performed a laboratory assay called electrophoresis. If you put anything in a gel or on paper and it has a surface charge, it'll either move towards the anode or the cathode. So we could actually separate things in the plasma. And what Friedrich Gunnar Bliss said is, hey, I want to separate the various proteins in our body. What type of proteins do we have? And we have alpha proteins, beta proteins, gamma proteins, and albumin. So he said, let's separate them in the blood. And to their shocking surprise, they saw, wait a minute, two of these lipoproteins are carrying a lot of cholesterol. And especially the beta globulins have the most, the alpha globulins less, and albumin and gamma globulins almost no cholesterol. So they proved that cholesterol to circulate in your plasma has to be attached to a protein. And this is where the terms alpha and beta lipoproteins evolved. And we still use these. The overwhelming majority of people going down with heart disease today have an excess of the beta lipoproteins. And you will see more on that as we go. So here is the probably most groundbreaking thing. In 1949, Goffman, with his fellow Frank Lingwin, published two seminal papers telling us that, yes, lipids do float around, bound to proteins in gigantic macromolecules called lipoproteins. And if I put serum in an ultracentrifuge and I spin it for 2 days, I got different types of lipoproteins based on their buoyancy and density. And I think you know what those names are, and we'll teach you in a moment. By the way, the centrifuges he used were those that came out of the development of the atomic bomb. You probably know physicists, when they have radioactive elements, they separate them in ultracentrifuges. So they said, hey, you're done with the atomic bomb. Can we borrow your centrifuges and look at lipids? And they did. And look, his fellow, Richard Havel, went on to do more sophisticated development of the ultracentrifuge, and it then became the standard of care for measuring lipoproteins, and it still is to the year 2024. Now, nobody is doing ultracentrifugation out of research labs because it's super complicated and doesn't have high throughput, so you can't order ultracentrifugation of your lipoproteins, but it's out there. In 2007, the magnitude of this discovery was so immense that the National Lipid Association developed an award, lifetime membership in the NLA, and Goffman was still alive, and he got the first such award. It's given on an annual basis ever since to the gods of the lipid lipoprotein world. So I think we're going to teach you about what a lipoprotein is. It's a lipid transportation vehicle that has to be soluble in plasma because your plasma is an aqueous solution. So on the surface are the two lipids that have some water solubility. The polar sides of phospholipids and free cholesterol are on the surface of this particle. Inside are the very hydrophobic lipids, and it's the massive lipids that are floating in your bloodstream, that cholesterol ester and tubby triglycerides, 3 fatty acids stuck on a glycerol molecule, and there it is. But listen, that's an oil droplet. There's no prayer that could exist in your plasma. So how did evolution say, hey, this thing has got to take lipids here, there, and everywhere? What did evolution have to stick on it? A globular protein, because proteins are soluble in water. I told you they discovered that in 1939 with electrophoresis. So that is a lipid transportation vehicle, my friends. The globular proteins that are structural, that wrap the lipids, providing water solubility, are called apolipoproteins. And actually, we're up to about 20, 25 different types of apolipoproteins now, but there are 2 that are structural. And you see one there, that big, dark brown thing. That's called apolipoprotein B. All right, so let's delve into these lipoproteins more. Family picture. So up top, now on the y-axis is buoyancy. Buoyant particles float. Dense particles sink to the bottom of the centrifuge tube. And on the x-axis, you see the diameter of the particle from very small on the right to very large on the left. So you see that I've separated the beta lipoproteins, and their distinguishing characteristic is they have a single molecule of apolipoprotein B on them. By the way, if you ask your laboratory, and every lab in America will do it overnight, give me an ApoB concentration, you are counting the exact number of those particles that you see there. By the way, those are the only lipoproteins that have the potential to cause atherosclerotic plaque. So that's why ApoB has become the sine qua non blood test that you have to be doing on everybody today. So on the right are your alpha lipoproteins, better known as your high-density lipoproteins. And you can see their structural protein, no ApoB on an HDL. It's apoprotein capital A1. And there are from 1 to 5 ApoA1s per particle. So that means ApoA1 is a useless blood test to you. You can't judge HDL particle count by measuring ApoA1. But ApoB, you can certainly use it because there's 1 ApoB per particle. Why are the beta lipoproteins so much bigger and so much more buoyant than the very dense HDL particles? Because they carry a hell of a lot more lipids. And in my diagrams, what does the color blue represent? Triglycerides. So it's triglycerides that determine the size of your lipoproteins. And the big fat guys on the top, the chylomicron that comes out of your intestine and the VLDL that comes out of your liver, are delivering triglycerides that you ate and the intestine manufactured or the liver synthesized. And where do they deliver the triglycerides? Incredibly rapidly to your muscles. Muscles need those fatty acids to oxidize for ATP. So the only purpose of chylomicrons and VLDLs is to provide energy. And when the chylos or VLDLs lose their trigs, what do they become? Incredibly smaller ApoB-containing lipoproteins that are carrying very little triglycerides. They're called your low-density lipoproteins. It's a cholesterol-carrying particle. By the way, I told you Goffman discovered these particles in the 1940s. Sooner or later, they knew there were proteins on there, and they just called it the A protein and the B protein, alpha and beta lipoproteins. And it wasn't until the late 60s, 70s that the lab chemists actually were able to discern the makeup of these various apoproteins. And then they began in the 1960s to be called apoproteins or apolipoproteins. There's the family picture of the beta lipoproteins. And I want to introduce you to the concept of plasma residence time. Notice the chylos coming out of your gut, the VLDLs coming out of your liver, float around for very few hours. They're postprandial lipoproteins. And that's why if you have trigs, you usually do a fasting lipid panel because the trigs would be gone by 2 to 4 to 6 hours. But notice the LDL floats in your plasma for upwards of 4 to 5 days. Wonder why? Why did evolution want? That's the number one killer particle that can cause atherosclerosis if it ever enters your artery wall. Why would evolution want them to hang around for so long? Answer is coming up. But I do want you to know, if you're measuring apolipoprotein B, which I know you're all going to start doing on Monday morning, 95% of your ApoB particles are LDLs. So in essence, ApoB is equal to LDL-P, LDL particle concentration, the number one potentially most atherogenic lipoprotein. Not all LDLs are atherogenic. So with this slow trigger here, my talk is going to take twice as long. All right, here. Yeah, I got to back up here. Let's try it again. All right, I got $1 million question for you. Why did evolution give us lipoproteins? What the heck do they do with the lipids they're carrying? Have you ever thought about it? Chilos and VLDLs, I told you, well, they're bringing trigs to the muscles, but there's a lot of cholesterol in these lipoproteins. Where are those lipoproteins bringing the cholesterol? Here comes the answer, and it was known back in the 1950s. Now I'm introducing you to two more of the absolute giants of lipidology. Both ultimately became directors of the NIH, and you see Don Fredrickson on the left and Robert Levy there. Very interesting, in 1966, in a German journal, they published an incredible review, and they answered the question, what are lipoproteins doing? The main reason the good Lord or evolution gave you lipoproteins, I have to introduce Robert Lees, not that he's going to answer this question for you, but together with Fredrickson and Levy, in 1967, I believe, they published probably the most important treatise of lipids ever published. If you really want to know lipids, this is a free download on the internet. It's a 5-part series in the New England Journal of Medicine. When did the New England Journal ever publish a 5-part series on anything before or since? Never. And they, if you're of my age, you remember, oh my God, we had to memorize the 5 types of lipid disorders, type 1, 2, 3, 4, and 5. Those terms are not used anymore. If you're using them, you got to learn the new terms. But they told you these are the genetic lipid disorders that are out there. So back to the question now. They said, look, the reason you have lipoproteins is to traffic triglycerides, energy to muscles, and if the muscles don't need energy, the trigs will be dumped in your adipocytes for storage. That's why VLDLs and chilos carry triglycerides, energy. Your heart could not beat unless those particles were delivering fuel to your myocardium. So thank God they are, because it looks like everybody's heart is beating in the room right now. So triglycerides are getting to your heart. They go on to explain, but if you just look at lipids in a fasting state where you won't find VLDLs or chilos, all of the lipids in the blood are not triglycerides, they're cholesterol, and then they're in your LDLs and HDL particles. Okay, wonder what they're doing in those particles. They have to do something with them. Now, I know you were all taught, oh, the LDLs are delivering cholesterol to the cells in your body. Erase that from your brain if you think that. No cholesterol is delivered to the cells by the ApoB-containing particles. The HDLs do actually deliver a little bit, but I'll tell you to who in a moment. All right. Phospholipids, they say, hey, they're just basically on the surface as detergents because they're soluble with water. But what we since learn is when those big VLDLs and chilos lose the trigs and they shrink, the phospholipids break off and they bind to a phospholipid transfer protein, which races them down to little baby HDL particles that are starting to mature. By the way, HDLs are manufactured and mature in your bloodstream, not in any organ in your body. So if phospholipids weren't being delivered to ApoA1, the HDL structural protein, you couldn't have HDL particles. So that's what phospholipids do. All right. They know that there is some net movement of cholesterol in plasma, but it's of small proportions compared to glycerides, no more than a few grams a day. So way more triglycerides in your bloodstream than there is cholesterol initially, but there is a little bit of cholesterol. And they said, hey, 1 to 2 grams comes from your intestine. That's the cholesterol you're absorbing, depending on what your liver put in the intestine or what you ate. It's a combination of both. And once the chilos enter your plasma, it joins with what they call a very small amount of cholesterol coming from where we don't know. What we know now it's the cholesterol that was effluxed out of cells into your HDL particles. So that's where the rest of the cholesterol in plasma is. So let's take you through a graphic evolutionary trail. So any cell with too much cholesterol will sense it and say we either die or we get rid of it. So they efflux the cholesterol out through a cholesterol efflux transporter, 8BCA1 transporters, into baby HDL particles or unlipidated ApoA1. Once they acquire the free cholesterol, they carry an enzyme that esterifies it with a fatty acid, creating the very hydrophobic cholesterol ester. The HDL develops into a balloon. It was a flatbed truck initially. So that's how your HDL particles form. But everybody know their HDL cholesterol now? Probably. So my question to you is, where the heck did your, say you have a 50 milligrams per deciliter HDL cholesterol, where did they get it? Where did they get all that cholesterol? Is it just being effluxed from your arteries, from your cells that have it? Nope. Almost all of the cholesterol in HDL particles is put there by your liver or your small intestine. What? It's the liver and the intestine filling your HDL particles? Why? What is the HDL going to do with that cholesterol? The HDL delivers the cholesterol to steroidogenic tissues, your gonads or your adrenal cortex, or it brings them over to adipocytes. We all think of adipocytes as triglyceride-storing organs. They're big-time cholesterol-storing organs also, in case you need it in a hurry. This enables both HDLs and LDLs to return cholesterol to the liver. Wait a minute, LDLs bringing cholesterol back to the liver? I'm going to show you a great slide in a moment. When HDLs fill up with cholesterol, they ship it over immediately. Hey, LDL, take my cholesterol, and you do something with it. Who knew HDLs worked in tandem with LDLs? Was anybody taught that? Maybe if you were in med school last week or something, but probably not before then, and it's still not being taught. Here it is. Here comes that big fat HDL. Now, floating in the plasma are your LDLs. And it says, whoa, let's use this lipid transfer protein called CETP, and it innervates, this is the wrong word, but it penetrates the LDLs and HDLs, and there is a swapping, one triglyceride molecule going from the LDLs to the HDLs in exchange for one cholesterol ester molecule going to the LDLs. And what does the LDL do with it? Immediately brings it back to the liver. There are two major particles doing reverse cholesterol transport in your bloodstream, and LDLs are doing half of it. It's not all HDLs. The only purpose you have LDL particles is to bring cholesterol back to the liver. They don't deliver cholesterol to cells under normal circumstances. So, wow, take that to the bank. And now when the HDL acquires triglycerides from the LDL, oh no, HDL should have almost no triglycerides in them. But once they acquire trigs, lipases catabolize the particle, the HDL shrinks, it becomes a baby HDL, it starts life all over again, or it explodes and the ApoA1 goes over to the kidney and gets catabolized into amino acids, which gets peed away. Wow. By the way, when an HDL brings cholesterol back, well, I'll show it to you here. So, all the cholesterol is going back to the liver or the intestine. I'm just going to show you the liver here. So how does the cholesterol in all your particles, including HDL, LDLs, VLDLs, chylos, ultimately get back to the liver? The liver upregulates specific receptors. The LDL receptor-related protein recognizes the ApoB48 on chylomicrons, or the multiple copies of ApoE that are on chylomicrons and VLDLs. And that's how the cholesterol in those particles get in. If you're absorbing cholesterol today after breakfast, your chylos are bringing them back to the liver now, and they're being internalized. And that's how your absorbed cholesterol makes its way to the liver. The LDL receptor that Brown and Goldstein got the Nobel Prize for is internalizing your LDL, IDL, VLDL particles. And that's how the cholesterol in them get back to the liver. And what about HDLs? The liver upregulates the scavenger receptor B1, which doesn't internalize the HDL, it delipidates it. So that's how the cholesterol in your HDLs. My friends, every single particle you're looking at there is performing reverse cholesterol transport. Stop telling your patients, stop believing yourself that HDLs are the key to reverse cholesterol transport. HDLs are the key to accepting cholesterol that cells want to get rid of, but then the HDL has about 6 avenues of what it can do with that cholesterol, and the biggest avenue is giving it to LDLs to bring back to the liver. When an ApoB particle brings it back to the liver or intestine, I don't have time to teach you that, that's called indirect reverse cholesterol transport. If the HDLs are bringing it back, it's called direct. The total concept of reverse cholesterol transport is the sum of direct HDL-mediated plus indirect LDL-mediated. Stop telling people, oh, your HDL cholesterol is this. It tells you nothing by itself about reverse cholesterol transport, nothing. So stop saying that. Direct and indirect reverse cholesterol transport. All right. One more concept to blow you away with, and this comes from the 90s by some really good people who were doing unbelievably complex studies of cholesterol in cells and pools in the body. And they said, look, the liver is the overwhelmingly important site for LDL clearance from the plasma in every species that's ever been studied, including humans. The small intestine and all of the remaining extrahepatic organs get about the remaining 30%. And that's that TICE, transintestinal cholesterol efflux. What would the intestine do to any cholesterol brought back to it? Transfer it to the gut lumen and you poop it away. So that's one way cholesterol gets out of the body. Within this latter group, large and important organs such as muscles and the CNS get zero cholesterol from that floating in your bloodstream. Wait a minute, cholesterol is the most important molecule in the brain, and yet there is not a single lipoprotein in your plasma delivering cholesterol to the brain. That's why you can have an LDL cholesterol of 5 and your neurologic function is perfect, because the brain doesn't get cholesterol from circulating lipoproteins. They can't cross the blood-brain barrier. The brain, starting in utero, mostly in childhood, but continuing through adulthood, synthesizes every molecule of cholesterol it has. You know what the half-life of a cholesterol molecule in the brain is? 5 years. What's the half-life of cholesterol in plasma? 3 days. So you could see the brain is a just totally different organ. The brain didn't want to depend on the plasma to deliver cholesterol. We would have never evolved. So the brain says, we'll just make it ourselves, and we're starting it. Initially in mom, the little embryo is getting some cholesterol from mom, but sooner or later, the embryo's brain, the fetus's brain, takes over and just starts making itself. Do you realize almost all the cholesterol molecules in your brain are put there during childhood? And then there's a much big slowdown in cholesterol production in the brain because the brain conserves its cholesterol. That's another lecture I have to come back next year and give you. Thus, in the whole animal and presumably in humans, most cholesterol is synthesized and utilized in extrahepatic organs, while most of the cholesterol carried in LDL is taken up. Every single cell in your body makes all the cholesterol it needs. No cells other than the steroidogenic tissue need delivery of cholesterol. And the HDL takes care of them, not the LDL or the VLDL. The beta lipoproteins deliver triglycerides. Another cool cell. Let's look at the various cholesterol pools that exist in human beings. Now you could see there's a lot in the liver, and floating in plasma, there's a lot. And actually, most of it is in all your peripheral tissues in toto. But I left something blank. So another trick question. I want to know, where is the cholesterol in your bloodstream floating around right now? Would I just look at the lipoproteins? Or is there something else in your blood carrying more cholesterol than lipoproteins? Red blood cells. Look up the diameters of a lipoprotein in microns or nanometers to a red blood cells. I mean, it's like a balloon to a marble. So, and what does every red blood cell have? A cell membrane that's full of cholesterol. We are also learning now that those red blood cells are in play. They exchange cholesterol with various organs and with lipoproteins. So they're an integral part of the cholesterol homeostasis system. More on that later. We're in our infancy on that topic. So it is in your peripheral tissues. And why did I say peripheral? Is there any other type of tissue in your body? That's not peripheral, that's the brain. Oh, CNS cholesterol, although significant in mass, is not considered in these models because it has zero interaction with the cholesterol in your liver, your blood cells, or your lipoproteins, or your other tissues in the body. Look at the brain contains 25% of the body's total cholesterol, and the brain, compared to the rest of your body, is like a little organ, but it just carries so much more cholesterol because it makes it and it preserves it. Lipoproteins in the periphery of the blood, we're getting rid of them all day in our stool or being converted to other things. Oh no, so here's what you really have to know. You'd never want to see anybody who's got an artery looking like that. By the way, is that triglyceride in that, in the wall of the artery? No, that's cholesterol. And how does it get there? Here's the billion-dollar question. In plasma, I drew the cross-section of the artery, and there are your beta lipoproteins, the ApoB particles, and they vary in size, little to big. And you know the endothelium is a barrier separating the wall of the artery from plasma. Over time, once those ApoB particles exceed a certain threshold, they're going in. Now, this occurs over a decade. You don't develop atherosclerosis over the next 2 weeks because you ate some bad stuff. No, it takes decades to get in there. But once the ApoB particles enter the artery wall, they bind to the connective tissue in the artery wall, they aggregate, they oxidize, they get ingested by macrophages, and oh no, there it is. It's plaque that Verpal discovered a couple hundred years ago. Wow. If you keep ApoB concentration below those physiologic levels, this cannot happen. And that's why ApoB is your most essential marker. Now, maybe you think, oh, but LDL cholesterol is the same as ApoB. That's another piece of fiction, if you've ever been taught that I'm going to dispel real soon. All right, there it is. And remember, of the ApoB particles, 90 to 95% are LDLs. So respect LDL metrics. Little diagram I did. Over time, the ApoB particles get in, and there's what you can wind up with. And notice up top, it says, hey, this takes decades to develop. It starts in childhood. Do you know how many autopsies we have from soldiers from all the wars we've been in that show their arteries are full of plaque? They're not going to have heart attacks for about 20 years. But this process starts. Bogalusa Heart, P-Day, Louisiana kids get hit by a train, they get autopsied. Fatty streaks and even an artery plaque in childhood because ApoB levels are high early in life in most of us. Those who have genetic issues where you don't make ApoB particles just cannot get atherosclerotic heart disease. Don't you wish you inherited those genes? Real small numbers of people do. All right, so now I got to extol Bill Roberts. He died last year. A genius. He was actually the editor of one of our most prestigious cardiology journals, the American Journal of Cardiology, for 40 years. What editor ever stays there for 40 years? But he loved what he was doing. In his younger days, he dissected more coronary arteries probably than any other human who's ever been born. And so as the editor of the journal, he could write any editorial he wanted because he's writing it. Who's going to say no to him? And in 2012, what an article. It's the cholesterol, stupid. Now, I would think he's like me. Was he born in New Jersey using that type of language? No, he's a Texan with a great accent there. But he wrote, look, the lower the LDL cholesterol, the better, and this principle has been established repeatedly despite voices of the anti-cholesterol, anti-statin fallacy mongers. It's the cholesterol, stupid. So it's a 2-page editorial, heavily referenced. Please read it. But heck with him. We're now looking at 2017 and 2020. The European Atherosclerosis Society, Europe is always way ahead of us with the lipid stuff for whatever reason. I think because it's the National Health Services there. There's no politics involved with their lipids. Anyway, they published 2 papers using these 400 references declaring that LDL particles are causal for atherosclerotic heart disease. But wait a minute, what's inside an LDL particle? Cholesterol. But what wraps an LDL particle? Apolipoprotein B. So ApoB, LDL cholesterol are now recognized to be the 2 most important causal markers of atherosclerosis. There are others, but in the lipid world, they're at the top of the chart, so to speak. Again, this is over time what can happen to you. Sadly, there is why atherosclerosis is still the leading global cause of morbidity and mortality. That means everybody's on the right side of that equation. Plaques are rupturing, causing fatal heart attacks or strokes. If you happen to survive that, it's called tertiary prevention. Maybe you could get taken care of. Nowadays, where we have such easy and cheap imaging, secondary prevention is defined as you did an image and I see plaque. You haven't had a heart attack or stroke yet. You're probably on your way, but it hasn't occurred yet. That should be use the term secondary prevention. You better get in with both guns playing there with your therapeutic advice. But here's where we need to be. Way on the left there. For years it's been called primary prevention. New term, primordial prevention. Early in life, preferably starting in childhood, you do lipid profiles, you do apolipoprotein B, and you measure something we're going to talk about called Lp(a). And if those are out of whack, you start with your therapeutic advice. And let's face it, in that stage of life, it's going to be lifestyle other than the genetic nightmares, which are going to require drugs even in the pediatric age group. So please, nutritionists should think of themselves as primordial prevention lipidologists. Don't wait till people show up with plaque. We can still do a lot of good, but early. So the rest of my talk, I'm going to have to zero in on the lipid risk factors. So this is your lipid profile that you looked at. Did you ever notice that almost all of the markers are cholesterol? The only non-cholesterol metric is triglycerides. The only reason you've been doing them is because until now they've been cheap, readily available, and that's the only thing you've been taught in school. So nobody ever taught you these are just poor man's markers of apolipoprotein B. And if you know how to look at a lipid profile and guess when ApoB is up, you'd be a lot smarter. All right. So the lipid panel does not report any lipoprotein concentrations to you. It reports lipid concentrations, in this country, mass, the weight of cholesterol or triglycerides being carried in all of the lipoproteins per deciliter of plasma. Basically, there are guesstimates of ApoB. Those are the population percentile cut points. You like to be below the 80th. If you're at risk, you like to be really in the bottom 5th percentile. So those are where your lipid concentration should be. By the way, you notice trigs, it says under 100, whereas guidelines tell you a trig of 150 is dangerous. And most people, a trig of 150, that's the 75th percentile of the human race. That's a nightmare, a trig of 150 until proven otherwise. So panic when you see a trig. I would tell you above 70, but we'll settle on 100 for this lecture. Now, goals of therapy. You know there's an LDL-C goal of therapy depending on your risk. Same with non-HDL cholesterol. I hope everybody knows total cholesterol is a waste of time. It's not a goal of therapy that you should be looking at. But how many in this room knows that there is no HDL cholesterol goal of therapy in any guideline that exists anywhere? And there is certainly no specific triglyceride. Yet I can't raise HDL cholesterol. What are you living in the 1990s? We've proven that raising HDL cholesterol doesn't reduce heart attacks. Why are you wasting your time on that? No guideline tells you have to raise HDL cholesterol. The guidelines are telling you got to blow away ApoB, and if you can't do ApoB, it's LDL cholesterol and non-HDL cholesterol. So stop thinking what you're doing to HDL cholesterol has any meaning with respect to atherosclerosis. It does not. Don't even repeat it, except it's going to always be part of a lipid panel, because all it does is add confusion. And promise me, all raise your hands right now, you will never look a patient in the eye and say, oh, you got high good cholesterol, you're protected. The graveyard is full of people with high HDL cholesterol. So, Paul Wood, at one time the most famous cardiologist in the world, from Great Britain, and his textbook was, boy, it was the thing. If you could afford it and you had that textbook, you knew everything about the heart. And he won about every award a doctor can win, so I won't belabor, but that textbook was the seminal textbook. What did he say? Hey, we can measure total cholesterol between 150 and 300, but it's really only a crude measure. Cholesterol is insoluble in water, carried in particles. I've taught you that. Bingo! In atherosclerosis, it's the absolute increase in your beta lipoproteins. In 1958, they didn't know what ApoB was. They were still calling them beta lipoproteins, but they are the ApoB particles. So Wood knew it in the 1950s that ApoB was the ball game. Why does nobody in America in 2024 know that? Why is that not being taught? Uh-oh. He knew a lot about lipids, but he didn't know he shouldn't smoke. And he died of a heart attack at a very young age. Hurst and Loeb, we're back over in the United States. Two of the early geniuses in cardiology, Cleveland Clinic and Emory University. Same thing. This is the 1960s now. Cholesterol is distributed throughout the plasma in lipoproteins. Stop being so preoccupied with cholesterol measurements. They're poor man predictors of the beta lipoproteins. So again, we knew this in the 50s and 60s, but why is it not being taught now? So, listen, in the 60s, Peter Apolovic came around. He goes, doctors, I know Goffman's been teaching you about high density, low density VL. Forget those buoyancies. Just look at the proteomic content of the lipoproteins. And the earlier lipoproteins, they weren't even calling it ApoB then. It was still the B protein and the A protein. But he started measuring apolipoproteins, and that was a whole new world of cardiology came into play. And this is the laboratory technique that does it. It's through ELISA antibody enzymes. I won't belabor that. But I have to read you this. This is 18 years ago. The 30-person, 10-country panel guideline. This was 30 of the world's top lipidologists, cardiologists who got together. And look, several of them are still, the second guy there, Christy Ballantyne, he's the current president of the National Lipid Association. But what were all these people saying? And there are a couple of women in there. Listen, all the national guidelines are focused on LDL cholesterol because this presumes that that's the most important metric. We now know, 2006, that risk is much more related to the ApoB particles, the number of particles that contact and enter the artery wall. Each of these particles contains a single molecule of apolipoprotein B, and you better be measuring ApoB. 18 years ago. Why is nobody doing it now except the lipidologists? And I'm going to just cut to the chase. I've worked with John Quantar. He's probably the best ApoB chemist in America. He's down in Richmond, Virginia. And listen, he says, I'm going to show you 4 LDL particles. 2 are big, 2 are small. The one second from the left and on the far right are full of triglycerides and not carrying cholesterol. So your LDLs are a mixture of numerous quadrillions of particles. Each and every one is different. So some are cholesterol depleted, some are cholesterol rich. You can't use LDL cholesterol. It's way too variable. So they said, look, there's nothing we can do to LDL cholesterol that can ever make it any better than ApoB. So let's all start just measuring ApoB in clinical care. And good news, there's now a World Health Organization standard that laboratories can follow. All right. I think I'm running out of time here. There's your ApoB particles. 95% are LDLs. It don't matter whether they're small or big. But look at the top left. You see the 4 metrics on the bottom. You see some labs will give you small LDLs, large VLDLs, smaller big LDL diameter, VLDL diameter. They are simple lipoprotein signatures of insulin resistance. Long before glucose goes up, long before insulin levels ever go up, if you were doing those metrics, you would know you're dealing with an insulin-resistant person. Probably best done in childhood, because that's when insulin resistance starts in our population nowadays. So ApoB is really an LDL particle concentration. All right. Total cholesterol, let's just jump right to the case here. Almost all of the particles making up total cholesterol are ApoB particles. Total cholesterol is a poor man's ApoB surrogate. Let's zero in on LDL cholesterol. You probably know it can either be calculated or directly measured. The Friedewald formula, which you simply divide triglycerides by 5, add it to HDL cholesterol, and subtract that from total cholesterol. That's your LDL cholesterol. And by the way, when did that come around? Bill Friedewald, 1972. Hey, I was an intern in 1972. Trust me, we were not looking at LDL cholesterol. It took about 5-6 years for it actually to get into clinical laboratories. Until then, we were just looking at total cholesterol. And HDL cholesterol appeared around that time also. So the direct LDL-C assays, what's the difference? The calculated is also looking at IDL cholesterol. The directly is just LDLs. If your patient has Lp(a), no matter what LDL cholesterol metric, that can contribute to it. It's a minuscule part of it for the most part. All right. LDL cholesterol is a poor man's ApoB, and I've begged you, stop using I'll use Bill Roberts' term, the stupid terms, good and bad cholesterol. I just told you an HDL takes all the cholesterol and it says, LDL, you take it back to the liver. So does good cholesterol instantly become bad? Please. And if the LDL's bringing it back to the liver, why is that bad? And that's what most of the LDLs do with their cholesterol. There's the assays. You can figure out how to do it if you want to start doing it in your basement. All right. These are your LDL particles. Just read that yellow bullet point. It's a silly blood test. It is so variable. Every lab has a different assay. You can't compare one lab's LDL cholesterol to another's. So stop banking the bottom line on that. Your liver secretes VLDLs. When they lose trigs, they become LDLs. We're all taught that. Here's what you are not taught. That about 40% of your LDLs are directly produced and secreted right out of the liver. So not every LDL is the grandson of a VLDL. How do you quantitate LDL particles? LDLP using NMR spectroscopy or ion mobility fractionation. Why not just measure ApoB? It's cheapest of all the tests. It's readily available. It's well standardized. NMR and ion mobility are not. So, and stop betting patient lives on LDL cholesterol. It's good. It correlates well with ApoB, but there are just so many cases where they don't correlate. They're discordant. So why, if you are looking at LDLPs, there's your total ApoB. It's a variety of all those particles. There's your LDL cholesterol. As I mentioned to you, you can measure small LDLP or small LDL cholesterol. Those are simply markers of insulin resistance, if you'd like to know that. Jim Otvos invented the NMR. Magnetic waves oscillate the proton groups in there, and then that signal, that spectral signal, can be calculated to particle diameters and particle concentrations. Ion mobility, which is Quest particle number, it's like a aerosolized electrophoresis. They spray lipoproteins into a chamber, they separate, and they measure them. HDLs, just read the bottom. HDL cholesterol has nothing to do with reverse cholesterol transport. It has nothing to do about the functionality of HDL particles, and it is not a goal of therapy. It's probably the biggest take-home point that you may need to know from today's talk. Commonly and erroneously referred to good cholesterol. Please don't get me started again. And HDL particles, if you really want a particle count, use NMR or ion mobility transfer. Stop using ApoA1. There's just too many ApoA1s per particle to make that usable. Those are your HDL subparticles. By the way, any single person you ever seen with low HDL cholesterol does not have big HDLs. If they had big HDLs, their HDL cholesterol would be high. And what's the biggest reason to lose big LDLs? Triglycerides get in there and the particles get catabolized. And that's why as trigs goes up, HDL cholesterol goes down. I'm going to just skip to the next slide because this is going to blow you away. Maybe it's my last one before they throw me off the stage. Do you know of all the lipoproteins in your plasma, 90% of them are HDLs? 90%! But they don't carry anywhere near the majority of cholesterol. So if you're measuring them by the companies that do them, HDLs are micromoles, LDLPs are nanomoles. So what is the difference? A micromole is a millionth of a mole, a nanomole is a billionth. It takes 1,000 nanomoles to equal 1 micromole. So when you get so many more HDLs than LDLs, when you get to your reports back, you may know that an LDLP range could be from 500 to 3,000. 500, thank you, Jesus. 3,000, oh my God, what undertaker is on standby. How many HDL particles do you have? The average person has an LDL particle count of around 1,000. They would have 38,000 HDL particles. And why do HDLs carry so much less cholesterol? The volume of a spear is a third power of the radius. Even a nanometer change in diameter translates to tremendous volume differences. Would anybody guess that it takes 16 marbles to fill a ping pong ball? You wouldn't, but it does. That's what cubing, the power of cubing does. Low HDL cholesterol, we all fear it. It could be a big risk factor. Now you know why. As HDL cholesterol goes down, LDLP on the y-axis goes through the roof. At an HDL cholesterol under 40, you have a high ApoB level. And that's why the goal of therapy in people with low HDL cholesterol is lower ApoB. Triglycerides, it's just the triglycerides in all your particles. And they're mostly in the ApoB particles. Labs just knock off the glycerol, measure glycerol, and convert that to triglycerides. Remember Margaret Albright, first person to ever use the term insulin resistance in the medical literature. And she compared it to hypertriglyceridemia. She called it glyceridemia back then. And why is lowering trigs not as important as lowering ApoB? Notice this trig goes up, up, up. Once you hit a trig of 150, you're in the nightmare range with LDLP and ApoB. But here's the most important thing to you. Why, when trigs goes up, does LDL cholesterol go down? Here's why. When trigs invade your LDL particle, which they shouldn't, that LDL carries a lot less cholesterol. It's a pathological triglyceride-rich particle. It takes a hell of a lot more cholesterol-depleted LDLs to traffic a given cholesterol mass than it does a cholesterol-rich LDL. So as trigs goes up, ApoB goes through the roof. And there's no triglyceride level at which you can say, aha, I've eliminated ApoB. You have to measure ApoB. And if you have, your triglyceride therapy is successful. And if you have not, even if you've made trigs 80 and ApoB is still high, you have more work to do. This is more of the same, the discordance. I'm going to jump very quickly. Non-HDL cholesterol is just a poor man's guesstimate. And here's the last slide I want to teach you. Lipoprotein little a. It is by far the most commonly genetically inherited atherosclerotic risk factor and also calcific aortic stenosis. Almost all of the aortic valve replacements being done now are in people who have high LP little a for decades. It destroys the aortic valve. And there's the guy who invented it, Carey Berg. 1963, there's his paper. And he says, hey, I've got a new LP system. What did LP stand for? Lipoproteins. What did A stand for? The antigen that he discovered on the LDL particles, which was apoprotein little a. There's an LDL particle. If you inherited the wrong genes, which are on chromosome 6, your liver will produce apoprotein little a. There it is. It's a bunch of loops called kringles, and it will just stick to your LDL particles produced in the liver. And you've created the most atherogenic lipoprotein known to human race. It's 8 times more potent particle for particle as far as an atherosclerotic risk factor than our LDLs. Fortunately, we have way more LDLs than we have LP little a. So even with high LP little a, we have to use therapies that get rid of the regular LDLs, and that's how you reduce heart attacks right now in people with LP. Next to last slide. Please, one-time test in every human being on the planet. Again, Monday morning, I know you're all going to be doing ApoB on yourselves and your loved ones, and you are going to do an LP little a if you haven't had it. And if that comes back positive, find out your nearest lipidologist or somebody who knows about LP little a. And this year, the NLA signed on to everybody once in your lifetime. And last joke slide. There are 2 types of lipoproteins A. One is capital A and one is little a. Capital A is your HDL apoprotein A. And be careful what you're ordering, because if you think you're ordering little a, the lab may send you big A, which is a useless blood test in the year 2024. All right. Hey, I can be contacted there. I probably exceeded my welcome time here, so I so appreciate not getting the hook.
Wow, thank you so much, Dr. Dayspring, for such an informative talk. We had an overwhelming number of questions, and we're not going to get time to go to all of them, but may I just ask you one or two brief questions? There is quite a debate about which is a more important dietary risk factor for elevated LDL cholesterol, saturated fat or dietary cholesterol. What are your thoughts?
Dietary cholesterol plays almost no role, except if you have genetic hyperabsorption of cholesterol. Not rare, but it's not, and that's out there. You should be measuring markers of cholesterol absorption if you want to answer that, and that's a lecture for another day, or please contact me. But other than that, so cholesterol is really not a player in most people. It's saturated fat. There's no argument on that. Saturated fat makes your liver stop producing those LDL receptors that Brown and Goldstein got the Nobel Prize for. And with LDL receptors, you can't clear the ApoB particles. That's why people who go on ketogenic diets, some of them, not all, send their ApoB into a malignant range. And to think that that's going to be the one-time exception in the history of the human race that high ApoB doesn't cause heart disease is maybe, maybe not, but I call it Russian roulette. So if you're on a ketogenic diet, you want to stay there and your ApoB is in the crisis range, find out what lipid drugs lower ApoB. And you know what? Sometimes they don't in that circumstance.
All right, thank you so much. Final question. Can your LDL cholesterol be too low?
No. What is LDL cholesterol? It's the cholesterol floating in your plasma in the most numerous ApoB particle. What is LDL cholesterol doing? Bringing cholesterol back to the liver. If there's no cholesterol in an LDL, there is no excess cholesterol in your system to bring back to the liver. Your brain is making cholesterol all day long, whether your LDL cholesterol is 0 or 300. Could care less, the brain. So low LDL cholesterol cannot hurt the brain in any way. There's just so many studies on this. And physiologically, if you understood brain lipid and lipochemistry, by the way, the brain has its own lipoproteins that have nothing to do with the lipoproteins in the periphery. No ApoB in the brain. You know what the brain lipoproteins are? ApoE containing lipoproteins. Hey, next year we'll get into that.
All right, thank you so much.